This week on the BackTable podcast.
Innovation nowadays, and it is more difficult because for better or for worse, maybe we were wrong. We tolerated complications for transplant. We have uterus transplant. There's a 15% prevalence of urinary injury. You couldn't do that with anything else, for the donor, not for the recipient. And so therefore, like transplant surgeons, what's the big deal? 15%, uretostenosis, they're saving lives. We're not, we're trying to make people better. There's a robotic surgeon here named Ziad Kaouk. He was showing me how he does prostate surgery now, right through the bladder. I mean, it's amazing what people can do and the innovation that's in, for our group. But this is how we learn from each other.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. And welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got with me my co-host, Dr. Amy Park. Amy, how are you?
Good. How are you, Mark?
I'm good, and we've got someone from your neck of the woods. We have a lot of big guests that come through this show. We've been very fortunate to have some pretty big names come through here. I would say, I don't know that we've had a bigger one than this one today. So we'll get to introduce our listeners to Dr. Tomasso Falcone. Dr. Falcone, Tommaso, how are you? And welcome to the show.
Thank you. Thank you for having me, taking the time to explore some ideas.
No, it's our pleasure. And so for our one listener who may not know, Dr. Falcone is a professor of OBGYN and reproductive biology at the Cleveland Clinic Lerner College of Medicine. He's a REI, reproductive endocrinology and infertility specialist by training. And he is an executive vice president at Cleveland Clinic and president of international operations and emerging markets, Cleveland Clinic. So, Tommaso, thank you so much for coming. As we like to do at the beginning of every episode, we like for our guests to sort of tell us, how'd you get here? So what was your journey? You can go into as much detail as you like, but it helps us, a lot of us, to understand the journey. So how did you get to your current position?
Well, so I trained in Canada at McGill University, and I did my residency and fellowship there under someone named Tomas Tulandi. He was the head of reproductive endocrinology. So I was a resident there and then a fellowship there with him. And then after I had finished, so I grew up in Canada, Italian parents, Italian neighborhood, as you would imagine. I went to school in English at McGill University, but the patients were French. So therefore, I spent my time speaking 3 languages every day until I moved to the United States. So that sort of gave me an international focus. And then growing up in Montreal is very international, as everyone knows, that has been there, and therefore gave me a perspective on international medicine. So I had a taste of Canadian socialized medicine, then came to the United States. I came here because the Cleveland Clinic, I just finished my fellowship, practiced for a few years, and then the Cleveland Clinic wanted to start a minimally invasive program and continue the IVF program. And so they recruited 4 people. One was someone named Jeff Milsom, who was a colorectal surgeon in New York. Someone from Quebec as well, named Michel Gagné, who was a general surgeon, but did big innovator in minimally invasive pancreatic surgery. Someone named Howard Winfield, who was a urologist and started doing a lot of laparoscopic surgery, and then myself to head up the gynecological focus. So then I came here, and after a few years, the previous chairman stepped down, so I was appointed chair. But I had no intention actually of staying here. We are Canadian, our family, my wife and I are Canadian. We grew up in Canada. We wanted to go back to Canada, but then we had children that grew up in the United States. And so we figured, well, we better become citizens because it doesn't seem like they want to go back. So then at that time, I stayed on as chair of OBGYN. We created a bigger and bigger department, and we're nationally ranked as one of the best. My link to Dr. Park here is she was a fellow. And although she's a urogynecologist, at the time, we did not have an REI fellowship. We had a few other fellowships, and the urogyne fellows spent some time with me in their first year. And specifically, they learned endometriosis, which is basically what I do. So they spent a lot of time, for those who were really interested, a lot of dissection, retroperitoneal, et cetera, and they learned to be surgeons that went away from the midline. A good colleague and friend, Mark Walters, would always say, I'm a midline surgeon. I don't go left or right. But we brought them that way. Anyway, so after OBGYN and, establishing a really, what I think is outstanding department, and I had done it for 15 years, I figured I wanted to do something new and different. And at that time, our youngest boy had just started college. So it was a good time to go somewhere else. And they were just starting Cleveland Clinic London. So my role was to go to Cleveland Clinic London. For those that have been to Cleveland Clinic London, it's across the street from Buckingham Palace. So for 5 years, we lived there, my wife and I. My role is exactly what you were talking about before: chief of staff, chief academic officer, and medical director. So chief of staff, because I recruited all the doctors, very few gynecologists actually, but most of those doctors like cardiac surgeons, et cetera, to build the clinical programs. So I was recruiting doctors and establishing programs. Medical director, because that's the official term for the person who was the leader of the pool, medical pool. And then chief academic officer, because it was my role to build the academic medicine as well, and basically recruiting. And remember, so I was there from 2018 to 2023. And at that time, it was COVID. So all the construction, all the recruitment of every doctor, interviewed almost 1,000 doctors. We hired about 250. It was all done with a promise that we would have this beautiful hospital and we would be finished with COVID. And then at the end of the time, I became president of that hospital and opened it up and so on and established clinical programs. And then at the end, it was time to come back. And I was still interested in an international role. So I became, at that time, the executive VP and then president of international operations in emerging markets. So what I'm responsible for now is anything to do with, basically moving patients around internationally. So if they want to go to Cleveland Clinic Abu Dhabi or London, Florida, or here, we have a group. We also have Cleveland Clinic Canada and in Toronto, and Cleveland Clinic in Nevada, which are emerging markets. And finally, we have relationships with affiliations in Mexico, in Chile. We have Cleveland Clinic connected in Vietnam and a variety of other places. So that's my role. So I get to be international again. So that's what I do. But I also have a clinical practice, which is highly focused on endometriosis. So that pretty much sums up 25 years in 4 minutes and 30 seconds.
I do want to say, just as a footnote, as being like on the sidelines, well, involved and so lucky to be one of your trainees and mentees, but it's like there was no minimally invasive, there was no robotics, there was no MIGS. This is all predating all of that. And interestingly, when I look at MIGS now, and I've said this, and I think a lot of people have the same take, but I mean, MIGS is really where Urogyn was 20 years ago. And you're one of the few REIs who does the surgery. The SRS is the Society of Reproductive Surgeons.
Yeah.
Mindy Christensen, one of my colleagues, is the president of that organization. But I heard it's the same 20 or 30 surgeons. Same ones, like all the
same group. Like when you look at IVF versus, reproductive surgery, I always tell people, why do a lot of IVF doctors not do as much surgery anymore? I said, well, let me tell you an anecdote. One Monday, I was doing three surgeries with the colorectal people, and they needed bowel resection. All three. We would just bounce from one room to the other. We started in the morning, 7:30. We finished at 9 p.m. Very tiring. I went home. I stayed up all night because I was wondering, did that patient do well? Was I too close to the ureter? Is she bleeding? Et cetera. And then on the same week on Wednesday, I did 3 egg retrievals, 2 embryo transfers, went home at 3 p.m. and slept all night well. So this is the reason why.
And get paid a lot more for your Wednesday than your Monday, probably.
You got it. The colorectal surgeons did well, though. But the gynecologists, We don't get paid for it, whether you have early stage disease or bad disease.
Well, that was Alan DeCherney's article, right? Initially, he wrote an article about, the transition of the open surgery to the laparoscope, and then wrote a follow-up piece about 20 years later, REIs are replacing the laparoscope for the lab, and saying this is kind of the transition. And that was right around the time of my fellowship, and I realized someone's got to be doing these surgeries. It's just a different way of practicing for the reproductive surgeon. So when someone else has to pick up the mantle for endometriosis and fibroids and pelvic pain and all that stuff. And so that's where MIGS came in.
Yeah, the MIGS surgeons, they're very good. REI has evolved. There are still people that do surgery, but it has evolved into very much understanding basic science, like cell cultures and genetics and the whole thing like that. So it is very complex, but it's much more cognitive. And so the surgical part has evolved towards the MIGS surgeons. But, the good thing in this institution, at the Cleveland Clinic, is that the MIGS surgeons, the REIs, we have joint meetings, we discuss, because there is an overlap. In a patient who just wants to have her uterus removed or endometriosis removed or for pain or something, it's pretty straightforward. But in a patient who wants infertility, oftentimes IVF, pretty straightforward. But if you have an overlap of those two, that's when it requires insight and experience and what to do with these patients. So fortunately, our MIGS group, the REI group, work same institution, side by side.
The MIGS, do you guys do a lot of fibroids too, not just the endo?
Right, we do. Fibroids, basically just like the MIGS people will do, extirpative surgery, so hysterectomies. Well, we do a lot of fibroids, but again, we have a tendency to be very conservative. If someone is infertile, has fibroids, they may not need any surgery. The recent data, support the fact that although fibroids, for example, may cause decreased implantation, it does not necessarily mean that the surgery improves it. You see, so the concept is like someone having like melanoma or something on the skin. You remove the lesion, it doesn't mean that you've cured the melanoma. So therefore, the fibroids have a lasting effect on the uterus. And so therefore, we're just removing them. There are some that do, we certainly talk about it, but endometriosis, so the difference between those two diseases, you need to know pelvic anatomy, or else it's very difficult to do endometriosis surgery. Fibroid surgery, in my opinion, is an approach to removing diseases within the uterus, an orientation, because you can get disoriented very quickly. And I've seen disasters as people, remove big fibroids and then take half the endometrium with it, or that you're too close to the tube, especially, people doing it by mini-lap. It's really an exercise in orientation of removing the disease within an organ. Okay, you don't have to know, usually, sometimes you obviously do, but where the ureter is or how close to the bowel, etc. But endometriosis is truly a knowledge of anatomy. Where are you? And you can get very disoriented with severe disease very quickly. I think so. Endometriosis and fibroids is basically what we do. We obviously do a few other things. A lot of infertility surgeons are still very good hysteroscopists because of the fact that if you do not have an optimal uterine cavity outcome, no matter how good your embryos, it's very difficult to actually improve IVF outcome.
Well, honestly, I feel like we should have you on for 2 or 3 different episodes, to be honest. But I want to try to focus on endometriosis today just because, again, we could have multiple episodes on that. But you're someone who has seen patients with endometriosis throughout your career. What's changed over that time and what we know or what we think we understand about endometriosis?
The reason I got into in managing endometriosis patients is because when we started to do it by laparoscopy, I just finished my fellowship at the time in Canada. We were doing basically diagnostic scopes and some lysis of adhesions maybe. So nobody wanted to do it by laparoscopy because we were basically looking to see how we could do it. And it took a long time, and it didn't, as you said, didn't pay. And nobody wanted to do it. So therefore, I didn't mind doing it, and I don't mind, taking a long time. And I was a salaried assistant professor for the few years there. That was part of the group. And so we were surgically removing, and there were pioneers, obviously, in the field, like David Redwine, for example, who passed away, as you know. And he, you may not have agreed with him, but he certainly started to look at the disease a very different way. And I listened to him, and I said, he has something here. So if we look at what we had when I started 30 years ago, that was the beginning for me, was surgery and the birth control pill, non-steroidals, and a GnRH agonist, because leuprolide was there even then. 30 years later, we have a lot of surgery, the birth control pill, leuprolide, but now it's true we do have the GnRH antagonists, like oligolics, for example. So it is a step forward, but it is not a great leap for mankind, if I can paraphrase someone who did a great thing. Because although it's a pill and we give more flexibility, the concept is the same. It doesn't treat endo. It just shuts off the hypothalamic gonadal axis, the pituitary gonadal axis. So you're basically blocking in a more flexible way and a more tolerable way. We do not have any drugs that go specifically either to the fibrotic lesion, which is really the main area of research, for example, now around the endometriosis. We don't have anything for that. And therefore, when I started, we were operating, and we learned how to do the surgery much better with fewer complications. That is true. And so the modern MIGS surgeons are better than anybody that when they started. I think they learned, and now we have very low complication rate. We can do it, the equipment is better. So we can actually do the surgery with fewer complications, with more insight, more complete surgery, more understanding of the visibility, the phenotyping of the disease, the fibrosis that occurs with it. So we are better surgeons at endometriosis, far better, but we're still removing disease. And the medical therapy, again, we have a progestin, we have a birth control pill, we have non-steroidals, and we block the hypothalamic pituitary ovarian axis more efficiently, maybe more tolerance, fewer side effects, but we're still doing the same thing, but we're very good at it now as compared to before.
No, I was just going to ask, with advances in surgical techniques and technology, are we making progress on patient symptoms? I mean, again, like the outcomes, they may have better perioperative outcomes, but are they doing any better from a symptomatic perspective in the long run? Do we have that data?
We do, but like when you look at 7, 10, 15-year data, it's really quite delayed. So I reported 10 years ago my 7-year data. The 7-year data didn't have a crucial thing. We didn't realize at that time that we had to put patients on suppressive medical therapy to prevent recurrence. So what happened is, the initial concept, we did the surgery, then we put them on 6 months, maybe a year. So we did the bulking surgery, 6 months of medical therapy. Then we took them off the medical therapy, waited a year and asked them how they're doing. Well, that's true. That's what they do in oncology. You do bulk chemo and then see if you live. But for us, we realized that was not the right approach. The right approach is to keep them on for as long as they are in reproductive age or pregnant. So we learned, some nuances there. Then, of course, the most recent data, again, is that there is a big recurrence rate in patients that are not suppressed. So we did learn that we have to suppress patients post-op, and that's the standard now, till they want to get pregnant. We also learned a few other things from a fertility point of view. The fertility point of view, what we learned was that endometriosis is a pro-inflammatory disease and has a tremendous amount of inflammation. Many other diseases like inflammatory bowel disease, asthma, arthritis. We did learn that when you do in vitro fertilization and you do a fresh embryo transfer, so there's still a lot of inflammation. So therefore, the success rates were not as good. But what we do know now, the tendency is to do the egg retrieval, freeze the embryos, wait for the IVF patient to recover, put them on suppressive medical therapy, which we usually do for embryo transfers, and then do an embryo transfer, and the pregnancy rates are no different than a woman who does not have endometriosis. So what we learned is that for patients that are interested solely in fertility, we need to suppress the inflammation, which we can do quite well with progesterone. We did learn that. So again, is it innovative? Well, we did learn how to do that better. We did learn that IVF does not make endometriosis worse. as people think. But you do have higher complications when you're doing the IVF from the egg retrieval or something of that nature. But it doesn't worsen the disease.
Culturally, though, I remember this because I wrote some review articles and chapters with you in the late 2006 to 2009. That's when I did my fellowship. It was still a debate, like, should we be even excising all this endometriosis? Remember, it was just people would be doing biopsies and then they would like turn it in. And so it was like a totally different thing. And it was like excision versus ablation. That was also a big debate, which I think the culture has changed around that. And then I think that, oh, you don't think so? Oh, well, I don't know. I'm around all the mixed people, so I don't know.
Yeah, that's right. You're right. So, just to tell you the excision versus ablation story. So it's kind of somewhat unimportant, so if you have a lesion, if you have a lesion under the ovary, okay, just imagine the ovary, lift the ovary. You see the lesion, okay? You have a choice. You can burn it or excise it. If you burn it, what do you think is under there? The ureter. You can either, two choices, burn it and then burn the ureter, or laser the top of it and leave the lesion. So you have to excise the lesion. You have no choice. Now, if it's on the urosacral ligament, it is true, and you know where the ureter is, you can probably burn it or excise it and you get the same results if you can go deep enough. So there's no question, all those studies that they're equivalent were all done in patients with very early stage disease that was away from the ureter or the ovary, which we can talk about in a minute. So excision is mandatory if you want to remove all the disease, if you're near the ureter, or half the time you don't know where it is. So, or it's near the rectum. What are you going to do? Take your bipolar and burn it right on the right? No, you have to excise. So therefore, excision and the Cochrane review and the systematic analysis all say, oh, there's no difference. But within the parameters that you are dealing with early stage disease that is not near very important structures. Now, in the ovary, it is true that if you excise, you have less recurrence. You have probably higher pregnancy rate. But again, within the parameters of what you have to do. If you have a patient who has an endometrioma and she has no pain, and if you say, okay, I'm going to do IVF, well, removing that cyst is not going to make any difference in the IVF outcome under most circumstances, except those where it's so big you can't get around it to do an egg retrieval. So to that patient, you say, removing it is not going to make any difference. Keep the cyst. Now, if the patient has pain, then you have to operate. But many times, that patient with the ovarian cyst has endometriosis underneath it, which is probably causing most of the pain, the deep endo. And then finally, we do know that every time you remove the cyst, that you can cause damage. So you have to know, but sometimes you have no choice. You have to know the principles of removing an endometrioma in a way which you damage the ovary the least, which would means, minimal use of electrosurgery, using suture to close, maybe hemostatic agents, just the concept that you're just going to remove every cyst. And then finally, there's something that we use now, and it's called the Endometriosis Fertility Index. Now, this was pioneered by a gynecologist named Adamson, who was in California, and if you remove a cyst and the patient's tubes are beautiful and there are no adhesions, then the pregnancy rate will be fine or improved. How about that? If you remove the cyst and the tubes look like a wreck because there's so much scar tissue and the cul-de-sac is completely frozen, the tubes have no movement, the patient's not going to get pregnant. So therefore, you have to be far more conservative. So that's where there's an overlap between the MIGS and the infertility group. If the purpose is to become pregnant and the pelvis does not look like it will allow a spontaneous pregnancy because the tubes are affected, etc., then you have to be much more conservative with managing the ovarian cyst. And so the ovarian cyst can be managed by different energy forms. Don't overuse electrosurgery. You can use plasma energy, which is what I use, to ablate perhaps part of it. So I think that the experience that we have in excision versus ablation, it's not as clear as that. Under the purists in MIGS, some people say, not only do you have to remove the lesion, but you have to remove the normal peritoneum in case there's a microscopic lesion. What's a fundamental misunderstanding of the evolution of endometriosis? Because if you biopsy the peritoneum in an early stage disease, like stage 1, you will find that these implants will go away on their own. And in fact, we know this from the trials where people have not treated endometriosis and then resculpt them 6 months later. And they will find regression of disease in some patients, the early stage, not the advanced stage. So, to take it back to what are we closer to the pathophysiology of endometriosis? Most likely, we're closer, but the unifying theory of endometriosis is not going to appear. So, we're looking for those genes that predispose you. Well, it turns out there are multiple genes and probably none that will say, oh, you're going to get it for sure, just like many polygenic diseases. There's an environmental component. There's a component of, delayed childbearing. There's a multitude of different things, environmental toxins, Mullerian anomalies, obviously, if you have an obstructive one. So there's not going to be a clear pathway where you can say it's unifying and that we're going to have a tremendous burden of inflammation. It's like almost all diseases, infectious diseases. Think about it. Some people get influenza and die. Others get influenza, they have a snivelly nose. Why? Host response, etc. So the unified theory is not going to be there, which means that right now therapeutics is still based on a very primitive idea that we have to aim for the clinical manifestation of that disease in the pelvis or elsewhere.
Well, I think that's similar to cancer, and I've said this on the show a few times, but we're treating a disease that is at the cellular level or likely the DNA level with steel. And I think that ultimately you can't get it all. And these surgeons that say, well, I'm going to take all the peritoneum. Well, you're not. There's always, first of all, peritoneum left behind, always, right? You're not taking the peritoneum off the sigmoid and you're not stripping the entire belly. So what are we talking about? Over the uterus, you're not taking the serosa off. There's tons of it left behind. There's always going to be disease left behind. And, your pelvis and abdominal cavity are reperitonealizing in 24 hours. We don't know much about. So down the road, we can talk about this too if you want, but the idea of what healing and all the changes that occur with that and the impact on that in terms of chronic pelvic pain or disease progress and those things. And so, as much as we have a better idea of how to manage the effects of the disease, it doesn't seem like we've made a whole lot of progress on managing the disease. It's or at least identifying the cause and truly addressing the disease at its nature, right? All the progress in cancer care is understanding how cancer works, right? Cutting off more didn't help in certain patients, right? It would just, if it was already spread outside of the initial organ,
the research though in cancer, for example, like immunotherapy is a big thing now, and treatment is becoming less and less invasive even. There hasn't been, and probably in different areas of gynecology, there hasn't been as much investment in research for benign disease like endometriosis or fibroids. So we are still, we understand the treatment better, what we should do or not do, right? So like I said, like if a patient says, I have no pain, we're not going to remove the cyst because we're not treating the pain. If she wants to get pregnant, we can do IVF, or she can do spontaneous pregnancy to remove the cyst, but it depends what the pelvis looks like. So there is more understanding of the therapeutic benefit of what we have today. But the interventions are the same over the last 25 years. Surgery, as we stated, minimally invasive, fewer side effects, highly skilled, like our MIGS group, that are being trained. I find them amazing. They can do lots of surgery very efficiently, very effectively, and with low risk in a patient. I just think that we must understand the disease sufficiently as to not overtreat, just like with fibroids and everything else. If you have fibroids and you have no symptoms, even if they're up to your umbilicus, why am I treating it? I'm not curing you. So therefore, I think it's very important to understand that overtreatment, causes problems.
The hardest thing to do in our specialty is to make an asymptomatic patient feel better. Right?
Yes.
That's a very challenging thing.
It is hard to stand down from, this problem that you see and you want to help with their fertility and do something, like there's just an urge to do something. But yeah, I know. I mean, I hear what you're saying though, because I know the arc of your career. Not only have you done all these amazing administrative achievements and surgeries, but you also had a basic science lab. And I remember we would like aspirate the fluid from the cul-de-sac and you were sent it to the lab and looking for the cytokines. And you mentored Elliot Richards, who's one of our amazing staff members here, doing the spearheading uterine transplantation and all the immune therapies that you have to do for that. So, I mean, you've been intimately involved in all these advances, but it's like, it is true. I mean, when you think about the cancer therapies and people are having all this precision genomic profiles and they're literally on, an angiogenesis inhibitor and some sort of immune blocker, and then having a genetic profile of microsatellite instabilities and looking at your prognosis. We don't have any of that.
And then the genomics, of the tumor, like brain tumors, like they have a total genomic profile that helps them with therapeutics. We don't do that.
Is that the future though? I mean, because honestly, the advances in cancer care have come in the lab and have come with targeted therapies.
Yes. And so so therefore it is different. But, fundamentally, we've been trying, so that you're right, the basic research, we're looking for is, the first research was on looking at what inflammatory cytokines do we have in the peritoneal fluid. So in inflammatory cytokines, there's a large group of them, TNF-alpha, for example. So we said, just tell you how you have to prove every step. You can't just say, okay, if you have an inflammation and I give you anti-inflammatories, you get better. So we showed, as many others, we have a lot of inflammatory cytokines in the pelvis. So when you treat Crohn's disease, you use these TNF-alpha blockers, right? So somebody said, oh, well, if they have a lot of cytokines, a lot of inflammation, I'm going to give them TNF-alpha blocker and look at their results. Well, the results were not spectacular because they used pain as the endpoint. So a lot of cancer trials, for example, what they'll do is they use the lesion, like if you have a lung cancer, so they give you medication, do a chest x-ray, your lesion's smaller. Okay, I guess it's working. What we did, not me, but someone, is they used symptoms. And they said, okay, let me see if the symptoms got better. Now, with chronic pain, the quote placebo effect of chronic pain is at least 30%. So what happens is that you have, 30% of patients get better with the placebo, and they didn't show any marginal improvement in TNF-alpha blocker. So every time, if you look at a study with anything, oftentimes for pain, they use placebo rather than a comparative group, because it's very difficult given the fact that a lot of chronic pain gets better during the clinical trial anyway. And the problem with pain is it's multifactorial, as you remember, for people that do pelvic floor. Even if you remove, I tell patients all the time, I'm going to remove all the disease, but you may still have pelvic floor pain. And it's the same as someone who has spine surgery. They still have to go to physical therapy. It's not like you get up tomorrow morning after spine surgery or shoulder surgery or neck surgery or whatever. So a lot of this is so complex that it's very difficult at times to show improvement in the actual pain symptom. I think, though, from the point of view of basic science, there are a lot of people that have, like Elliot Richards, who's here, looking at different models to see if we can understand better. If I tell you that the main thing that I would think nowadays that people are looking for is the fibrosis around the lesion. So the fibrosis, even, for you that have removed an endometrioma, what you're stripping off is the fibrotic layer. The actual glands and stroma on the inside probably covers maybe 30 or 40% of the surface area. That's why sometimes when the pathologist looks at it, she will say that it's a fibrotic cyst and nothing else because of the fact that it's not. So fibrosis in bowel endometriosis, tremendous fibrosis. So, those are the types of things which, we could aim for perhaps to see. Like in cancers, for example, they are working on fibrosis because the fibrosis prevents chemo or something from getting into the lesion.
But the fibrosis is more the result of the inflammation, of the tissue response to inflammation, or is that you think it's a primary part of the disease? I always sort of saw it as like scar tissue from an injury. I mean, it's sort of what's left over, and it's sort of irreversible. We can suppress the glandular tissue or the endometriosis tissue, but once the fibrosis is there,
it's there.
It's scar tissue, and now the only role is either surgery or PT or whatever.
I'm not sure anymore if the fibrosis is a result of the inflammatory lesion. Even in the ovary, the cysts themselves are highly inflammatory. And if you look at anti-Mullerian hormone, which is a sign of reserve, even without surgery, it's lower in patients that have endometriosis in the ovary cyst. But I'm not 100% sure anymore that it's a reaction. It could be simply part of the actual disease itself or in the evolution. In the last, I suppose, 2 weeks, I have seen early 20s, with advanced disease, which I removed, and I was kind of surprised, like I said, boy, this is really bad disease. One woman had bilateral 11 centimeter cysts from endometriosis. It was amazing. She was in the emergency room. You looked at her abdomen, and she was very slim. It was big. And I said to myself, why is this patient at 21 like this? And then I could do another patient at 39 and they have smaller lesions. And because I don't know if it goes from 1 to 3, 1 to 2 to 3 to 4, I think you probably are a 4. Like you start as a 4 and other people start as a 1 and stay as a 1. And sometimes it evolves. According to the studies, it's true. There was so much fibrosis. It was intense, like the amount of fibrosis there was. So I don't know, but I do know that we do need to look at it and see what happens. The admonition is always, just because you remove it, it doesn't mean that the disease is gone, meaning, or the symptom. Pain may not be gone, fertility may not be gone. It's not as clear as that. And the one that I feel that I disagree the most with are people that are removing at the naked eye is a completely normal peritoneum, and then you may find a microscopic spot. That is a misunderstanding, in my opinion, of the underlying pathophysiology of the way these lesions regress. In many studies, they exclude even stage 1 endometriosis because they're not sure of its contribution. So sometimes they start at stage 2, which we know is real.
But that's a big component of our REI MIGS world right now, at least a large subset of surgeons who are doing these, like I said earlier, peritoneal stripping that I think, colleagues like Frank too would argue, we just don't know what's, when this peritoneum comes back and the new nerves that are forming, and we don't have any sense that it's going to help. More importantly, we have really no understanding of the risks of these surgeries besides the acute perioperative complications and those things. But long term, we don't know what we're doing to these folks. And so I think it's I have patients that come say, I saw this person traveled away, came back, and they said they took it all out. And I'm going, but who's saying that to patients? Who's saying I got it all?
Yeah.
Right? I mean, it happens all the time.
Yeah, of course. Why not?
Well, I don't know, honesty, sleeping at night,
Well, I mean, patience. But you know what? Yeah, on the other hand, I can see it from the patient point of view. I mean, not just us for endo. I mean, they ask all the time, did you get it? Did you get it all? It's an attack. I mean, I don't blame people. I mean, people do the best they can, but I just feel that, becoming too radical for a very small disease, First of all, there are studies that show repetitive surgery can actually increase pain in patients with endometriosis. And so therefore, we have to be cognizant of what we're doing. But I have to tell you, the patients that were the angriest with me are the ones that I told them, I don't think I can help you with more surgery. Patients would come in from out of town. They would, spend 3 months to get an appointment. They come and I would take my time. I always take my time, review all the records before they got here. And I would say, look, if you look at these records, not one says on the pathology report you have endo. If the person on the operative report said you have endo based on, severe scar tissue or something. So there are two possibilities. Either it's still there or there was none. And that's not a problem. People just overcall it. And because they say it's complex, but that those patients are very unhappy with me when I tell them, I don't think I can help you with more surgery. Can we try something else? I'm not saying that you don't have the pain. I believe you. I'm not saying that we should not offer you some type of therapy. I will not, abandon you. But the surgery is not going to do it. I don't know how some patients come to see me. I had 6 surgeries by 25 years old.
Yeah, no, that's excessive. I mean, that is, Mark and I talk about this all the time. The community, it is a community, and you said this too. It becomes part of the identity and part of the support, and then you pull the rug under them and they're angry about it. I just wanted to pivot. I have 2 questions. One is, you've always had a sense of like innovation and surgery and research, and like you were editor-in-chief of JMIG. We didn't even mention that at the beginning of this session. Like, how did you hone your sense for that and like in your own career, number one? And number two, a lot of the surgical techniques you were doing for endometriosis and also robotics, you had to forge yourself. And Togus Tulande is obviously a super famous REI surgeon. I don't know, is he practicing anymore? He's probably retired, right?
He's actually chair of OBGYN still in McGill University.
In McGill, okay. But how did you pioneer the techniques and become a better surgeon? Because the anatomy and the spaces, and we just got better over time, but like you just had to like put yourself out there. I mean, Cleveland Clinic has very good lawyers, like because a lot of people are afraid of litigation and innovation. You know what I mean? Like, I feel like that's part of it. I mean, having a culture, you also set the culture at Cleveland Clinic for innovation for a long time. Like, how did you, and just individually, but also for the Institute, and then also, surgical techniques, like, because a lot of people in our section and in across the field honed their innovation and their surgical techniques here as well.
So the first thing is like innovation or being around at the right time. There's a certain amount of good luck, and like you happen to be there when it happened. For example, robotic surgery in the year 2000, the first robot, which they don't have anymore, it was called Computer Motion did it, and it was called Zeus. So they came to the Cleveland Clinic. So I happened to be here. I've been here for 4 or 5 years. I wasn't sure yet. So they came and they said, we have to, this robot will work if we take maximally invasive surgery and turn it into minimally invasive surgery, which would be cardiac. So they went to the cardiac surgeons and they said, we want to do this. If you look at the original studies, they're all with cardiac. So, but they were open. Nobody, you would put the robot after the chest was open. So when they wanted to do it, without it, they came down, and there was one surgeon here who said, oh, what we should do? We should try this in a same type of suture, which was the 8090 for coronary bypass. And then we're going to try it, though, in gynecology, because, you don't die if it doesn't work, So they came to me and they said, will you do the trial on tubal reversals? Okay, we use the 8090. And I just happened to be here, and the robots, companies were here with the heart surgeons and the other ones. So I said, okay, I'm going to try it, and let's see what happens. So I started trying it, and I did the first FDA trial in the world in gynecology for robotic surgery. Now it's a robot that doesn't happen anymore, but the concepts were that we were doing this. But I happened to be here. Then what happened, the reason why it didn't take off in heart surgery is because at the same time, they developed the stents. So the robotic coronary bypass surgery was meant for a simple disease. And the stent guys said, we don't even need a robot. But now they're actually going back in time for some of the stuff in cardiac. So I happened to be there first. Then the next phase, ovarian tissue cryopreservation and autotransplantation. That took off, and people said, oh, we're going to do it in this particular technique. I said, well, this is the time when I was doing it on sheep model. I said, hey, something? Let's try it with vascular anastomosis. And so the plastic surgeons here were developing all sorts of microvascular techniques. So that took off, and I was involved with that. And then the final one of the things was uterus transplantation. So again, I happened to be here, and at the time, I said, this is absolutely crazy. Why would anybody do a uterus transplant? Well, there happened to be a transplant surgeon named Andy Chakas, who was in Florida, who said, oh, no, it's a great idea. And I said to Andy, I said, no, I think it's a crazy idea, but I'm willing to listen. So I said to Andy, who was part of the team in Sweden, so this is maybe 10 years ago. So I said, I'll go to Sweden. I want to talk to the patients. Okay. I want to talk to the patients because they're the ones that are going to tell me the truth. Okay. And it's not going to be some crazy doctor. So Andy Chakas and I fly to Sweden to learn this. And at that time, Mats, who was the pioneer, truly the pioneer of it, I said, can I speak to the patients? The ones who speak English anyway. So I sat down and I said to them, why did you do this? Well, I want to have a baby. Well, why did you do surrogacy or gestational carriers? Well, Dr. Falcone, it's illegal in Sweden to use gestational carrier. In fact, commercial surrogates are banned in all of Europe and Canada. So it's actually, he couldn't do it anyway. And I said, and these patients were strong-minded. This is what they wanted. And we were responding. So I said, well, okay, maybe there's more to this than I thought. So we learned the technique. We flew back and we tried it on many cadavers when they were doing transplant. But there was a transplant surgeon named Andy Chakas, world-renowned liver transplant surgeon, extreme innovative person. If you look at something called the H index, it's one of the highest there is. And he convinced me to do it. And then, so I was part of the team that did the first one in the United States. So all this has to do with a mindset, being there at the right, you have to have luck too. You have to have a hardworking mindset and open to changing your mind about all of these things.
And being in the right place, though. I mean, you're at a place where innovation is prioritized and you're with other people who are like-minded. Yeah, for sure. It's an amazing place.
So the surgical skill is to be part of, learning doing something new has to be part of a team. Because if you're, as a solo player, it's very difficult on your morale, because you may fail, you didn't know if you did the right thing. But, I was here as part of a team. There was always a team. And the team were not necessarily in gynecology, I had the colorectal surgeons, urologists, and, to a certain extent, they're braver than we are because they accept, like a urologist, they accept that I injured the bowel, I cut the ureter, I'll fix it. For us, it's the end of the world. I have to tell the patient.
I know. It's true. The colorectal surgeons especially, they're like, bowel injury, no problem.
I'm going to bring up an ostomy. What's the big deal? No, it is a big deal. It is a big deal from my patient. No, it's just a little ostomy. I'll reverse it in 3 months. No, you don't understand. It's not that. I had the same thing with a thoracic surgeon. I was learning to do diaphragmatic endometriosis. I called the guy in. And the guy said, here's the diaphragmatic endometriosis. When we wake her up, we'll talk. No, I can remove it right away. I said, I don't know. I said, Tom, the guy's name is Tom. I said, should we really be doing this? I mean, after all, I don't want a complication. She's 22 years old. She came here with pelvic endo. No, I'm a thoracic surgeon. I can do anything I want. All right, I can. Fine, go ahead. So he takes it, and then 30 seconds later, I can see the lung. All right? So he says, oh, it's no problem. We should put a chest tube. No, I said, Tom, this patient came for a laparoscopy. She can't wake up with a chest tube. Do you understand this? This is not standard of care. And he's just, well, what's the big deal? I'll remove it tomorrow. No, it is a big deal. And anyway, he fixed it, and he didn't have to put a chest tube in. But you can imagine, they have a different level of things. Even our GYN oncologists, we hit a vessel, we'll sew it up. No, it's not the way we do it in benign disease. Not like we can't hit the vessel and put a few stitches in. So the same thing with these, you work as a team, and I learned from them. I learned a lot, from the colon surgeons and the urologists. Hey, they put a hole in the bladder. Yeah, it's okay. Just put a Foley in. Well, I don't know. I'd rather sew it up. But it did teach me about this, So we learned, I learned, when I first got here, I said, we need to do laparoscopic birches. Okay, so laparoscopic birch procedure. So I went to Mark. I said, Mark, I'd like to, I don't see your incontinence patients, but you do. And he was doing birches. And he said, I said, Mark, we do a laparoscopic birch. You're crazy. He said, so I said, no, we can try it. I mean, so I said, people are doing it all over the world. And then, of course, with the TVTs and all that afterwards, it went away. So the first time we did one, we got in the bladder within under 30 seconds. So Mark says, I'm never going to do this again. We don't do this. I said, well, Mark, just give me another chance. So you needed a team. And Mark, knew, obviously, I would put the stitches in. I said, this is look good, yes. But then I went to a meeting, and there's a guy there who died now. It was a year in London.
Stuart Stanton, yes.
He was doing TVTs, and he says, Dr. Falcone, and I was presenting the laparoscopic birch. He's an REI with it. And he says, what's your learning curve? So, and I said, well, what's the learning curve for TVTs? The guy goes, 4. He says, once you've done 4, you know how to do a TVT. How many for laparoscopic birch? I lied. I said, well, I think we can teach people with 12. Of course, you really needed 50, to do it. So the birch went out of, completely went out of thing, but I didn't mind doing it. But, the interesting thing when I was in London, they absolutely eliminated completely all mesh, even for TVTs. You can't do an anti-incontinence procedure.
Oh, yeah, I know.
With a mesh.
Yeah.
There's nothing
is
left.
Is it all native, fascial?
Birch.
Harvesting? Or?
Back to birch.
Yeah, birch.
Back to birch.
Yeah, they do a lot of bulkamid and it's a lot of pelvic floor ultrasound if you go to IUGA. So that's why, I'm just curious because it's the innovation and the culture of it, and then fostering it, and then also that pushing the envelope. And the curiosity, that just takes a lot of vision,
It does, but it's all part of the team. If you're a solo player, probably, but do you encourage it? Plus, I have to tell you that innovation nowadays, and it is more difficult because, for better or for worse, maybe we were wrong. We tolerated complications for transplant. We have uterus transplant. There's a 15% prevalence of urinary injury. You couldn't do that with anything else. For the donor, not for the recipient. And so therefore, and transplant surgeons said, what's the big deal? 15%. Uretostenosis. They're saving lives. We're not. We're trying to make people better. Anyway, so a lot of things, nowadays, that even for all the other surgeons, there's even in colorectal surgeons, the reason why on our institution, they bring up a lot of ostomies because they cannot take any leak. If a leak happens, you by prophylactically, does it prevent leaks? Probably not. But if a leak occurs, you're not taking the patient back to the OR for another surgery. So a lot of people have moved towards that. They don't mind innovation. There's a robotic surgeon here named Ziad Kaouk. He was showing me how he does prostate surgery now, right through the bladder, not like the scope, and then you take out, you disconnect the bladder from the urethra, take out the prostate. He puts the robot into the bladder, so they go into the bladder, and then they have the single port robot, and they remove the prostate gland. Not all patients that way, and that way you remove the scope, and all you're doing is closing the bladder. It's amazing what people can do, and the innovation that's in for our group. But this is how we learn from each other,
Your point about the teams is crucial, right? You've got people who are comfortable doing things that you're not comfortable doing. We've talked about that a bunch in the show. But the other piece is expectations. And I tell folks and, people I'm training, patients understand complications, I think. I think they don't like surprises. So when I talk to patients and I send them to my colorectal colleague and say, look, significant concern for colorectal disease, risk of an ostomy is not zero. It's something you need to think about and weigh. And do we want to focus more on medical management for now? And is that a road I want to go down, knowing that that's a risk? Informed consent, informed is a crucial piece of that. And so when they're part of the decision-making process, knowing that, whatever happens is fine. If they wake up with an ostomy, that's what we discussed. If they don't, they're happy. When you wake up with a surprise chest tube, it's a different thing entirely. So I try to counsel patients honestly, not try to scare them out of anything, right? It's to be truthful and say, look, this could happen. And so with endometriosis, we have to really think a lot more about those conversations that in the past with benign disease, cancer, sure, all sorts of stuff can happen. Endometriosis is not an easy surgery either. And ureteral injury and bowel injury and all those things are just sometimes part of it. And you can't, endo's wrapped around the ureter, you may have to cut that section of ureter out. It's not a small thing. And so I think the pre-op counseling and doing this a lot and doing it enough to know what could happen is a huge piece of, like what you said, is it's dealing with having good teams, but also really preparing patients for what could happen.
Yeah, managing expectations is the main thing. I always say under promise, over deliver, and then you got to focus on what your outcome is for endometriosis. Is it pain? Is it infertility? Is it symptoms? Of course, it's the goal is symptoms for urogynecology. Asymptomatic prolapse, don't touch it. Same with the fibroids, don't touch it. You know what I mean?
And make something better if it's pretty good to start with.
Yeah, exactly.
That's right.
Exactly.
Well, this has been pretty good, and that's an understatement. I know we've got a lot more we could talk about. I mean, we've kept you on for over an hour already. I would love to have you back on the show one of these days to talk about fibroids or about any of the other things you've done in your career. And now I'm a chief medical officer now, and so to understand sort of your transition into more administrative work, and what percentage clinical are you still right now?
So I'm approximately 25% clinical and 75% traveling salesman, almost.
I'm about 30% clinical, so I'm doing some of that myself. But we'd love to have you back on one of these days to talk about that transition as well. Personally, selfishly, I'm dying to learn more about it, and I'll definitely pick your brain when I see you in New Orleans in a month or so. I just want to say thank you for coming on the show. I've heard so much about you. I mean, you are a legend in our field. You are someone that if you're doing this work and you don't know who Dr. Falcone is, you're not doing this work. You're not paying attention, because you truly are one of the sort of the Mount Rushmore folks in our field.
Thank you.
Thanks again, and we'll see you back soon. Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Orvajinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers